I would like to thanks first to the committee members who are giving me the time to present my topic. So I am going to tell about the stoma complication and its management. So normally stoma complications are there. It is divided into early complications and late complications. Early complication can be managed by the medically, and if it is deteriorated, then it has to be managed by the surgery. So first early complication is the ileus, paralytic ileus. It means the absence of bowel sound. It will be normally like my colleague already told, the colostomy, if the ileostomy or ileal conduit is there, it will functioning immediately after the surgery. But in case of the transverse colostomy, it will take within 24 hours it will functioning. And in case of sigmoid stoma, it will within 72 hours it will functions. And cause of the paralytic ileus will be the excessive bowel manipulation during the surgery, or prolonged anesthesia, or patient is taking of medications, prolonged medications. Because of that, paralytic ileus may occur, and management for that, immediately the surgeons are putting the nasogastric tube to decompress the bowel till the return of the normal functions. In that case, some patient may complaining of the nausea, vomiting. So for that, patients are kept for NBM or in liquid diet. In that case, we are advising the patient to have the lukewarm water to get the bowel habit fast. Second is the hemorrhage. There is a bleeding. Hemorrhage is the mostly commonly possible after immediately surgery. So that causes will be the portal hypertension or bleeding disorder, or patients there is history of the patient may taking any blood thinner, or patient is immunocompressive, or chemotherapy will be going on. So that need to the history is properly required while giving when patient is telling about the hemorrhagic entry history. And in that case, we have to talk with the patient. We have to ask how much quantity of the bleeding is there, how frequently it occurs, and if minor bleeding is there, then it has to be managed by the light pressure. But in case of the active bleeding, then it has to be managed by the surgical interventions. There is the next will be the anastomotic leak. The anastomotic leak means the luminal content from the surgical joint it is because of the luminal content from a surgical joint, and if it is not diagnosed properly, then there may be chances of that patient may develop the severe sepsis, and it will be progress to the multi-organ failure. So anastomotic leak causes are the emergency surgery. If prolonged time for the surgery is take, in that case peritoneal contamination will occur. If patient is having the diabetes mellitus, if patient's obesity is there, malnourished, and if patient is taking history of the corticosteroids, in that case the anastomotic leak will be occur. So our main role is that patient will show the sign of the fever with chills, tachycardia and pain. So we have to evaluate, proper evaluation is required. So we are immediately post-op day. That's why we are using the transparent bag to evaluate the stoma. Again, so we are which will help us to understand the actual problem. This is the necrosis will be the immediately like within 2 to 3 days after that we'll find that if the normally, as my colleague already told you regarding the normal color of the stoma, it will be red, bright red, cherries red. But if when the color is turned to the bluish or blackish, then it means it might be there is the constriction sutures lying because of that, or during the surgery mesenteric tensions over the stoma suture line, or the wafers bag which is applying to the stoma, it is too tight to the stoma, or if the patient's physique is not good, like abdominal edema is there, in that case necrosis will be happen. So first is that evaluate the color, and for that clean observation is required. And if like this necrosis is observed, then it has to be informed to the doctor immediately. And if ischemic damage is more than the 2 centimeter, in that case surgical incision is very it's required. And for that proper second thing is whatever size we are cutting that according to the stoma side, we have to cut it properly. This is the late complication, like skin excoriation. Means the skin excoriation is the skin breakdown around the stoma. The causes beyond that that there will be wrong types of the appliance, or the stoma which is supposed to be well protruded, like the 1 to 2.5 centimeter from above the abdominal cavity. But if it is not properly matured, then there is chances that any bag will not stay on the stoma, and because of that all effluent which is there, which will be on the remain on the skin, and which we can't manage with the stoma. So this is the like that problem will be there. If the stoma stoma sighting is not done preoperatively, then that is the main reason that stoma, if it is placed on the skin creases, then it will lead to the skin excoriation. And if the proper bag is not applied according to the stoma, like a protruded stoma, if the stoma is flushed or retracted, then in that case convexity is required. And if like that proper bag is not fixed to the stoma, then there is patient may lead to the skin excoriation will be there. So that it has to be managed within the proper time. This is next will be the stoma prolapse. Stoma prolapse of the stoma means what? It is the telescoping of intestine through the stoma. The stomal height is increasing, and it looks like the edematous, and patient in that case the causes are the large opening in the abdominal wall, and because of the sometimes the patient may be doing the strenuous exercise, or during chemotherapy loose motion, continuous motion will be there, or coughing, patient is coughing, then in that case there is chances of loop can be prolapse. So management is that main thing is what, because of the prolapse of loops, that by any bag will not be fixed properly. So first is that accurate pouching, that will be helps to accumulate the stoma, and patient will be because of this it look like something abnormal. So advise the patient advise the patient proper pouch, which will helps to accumulate all the stoma. And surgeons sometimes we try to manually stoma reduction by themselves, but again it is coming out, and sometimes if it is not managed and continuously patient is complaining of the bag is not staying proper within, like in a day or in a 2 days they have to remove early every time. So in that case proper pouching, if it is not possible, then surgical repairs they are doing. Next is the peristomal hernia. Peristomal hernia is the defect in the fascia that allows loop of the intestine to protrude into the area of the vicus, and that will be the first causes will be like if the preoperatively many patients they are not referring to us, and if that stoma is not made within the rectus muscle, then there is chances that stoma may prolapse, or if the patient there is history of infections, or overweight patient, or obese patient, and the patient those who are having not abdominal muscle stone, in that case this peristomal hernia is there. So we are normally advise the patients to wear the whatever the appliance which has to be fixed properly and last for long period, that we are advising to them. Then we are advising the support belt, which will help the peristomal hernia. And again, if it is not managed with the pouches also or with the belt, then patient may go for the hernia repair. And pilot exercise is the which will helps to control that hernia. So these are the some pilot exercises which we can helps to hold the peristomal hernia. Next is the mucocutaneous separation. Mucocutaneous separation means the stoma is detached from the stomal stitches, and because there are the many reasons, because that is will be like excessive tension to the suture line around the stoma, or superficial if any infection patient is having, or impaired wound healing, like if the patient is the history of the diabetes mellitus or immunocompressive patients. In that case there is chances of that mucocutaneous separation is there. And main management is that nursing observation is very important in that key, to see whether the depth of that separation, intensity of the separation, and any collection is there or not, and according to that absorbent dressing is to be applied. Next is the stoma retraction. Stoma retraction is like the disappearance of normal stoma protrusion in the line with or within the skin level. So in that it will be because of the mesenteric tension during the surgery, or the inadequate stoma length is there, and the mucocutaneous separation, distended or edematous, or stoma necrosis. It will be managed by the convexity bag, which will help the stoma to come protruded. So next is the stenosis. Stenosis is the narrowing of the stoma, and which will be constructed. That reason will be the excessive scar formation or peristomal sepsis, and it will be managed by the gentle dilatation. So we are advising the patients to dilate by starting from the small finger, and it has to be seen regularly. So for that we are putting the two-piece bag, which will help the patients to dilate the stoma properly regularly. And even if it is not proper, it is then patient will go for the surgical repair. repair. If the folliculitis, it is the inflammation of the hair follicles. It might be because of the too harshly or shaving is done, peristomous shaving is done, or if patient is the obesity, malnourished patient, or if there is chronic staphylococcus infection, that will management, we are advising the patient to save layers, saving the lightly shaving of the peristomous skin, and in case if there is they can use the adhesive removal spray also. Allergic dermatitis will be because the prolonged long of the adhesive pouches system, so which has to be managed by the it has to be identified according to the antifungal whatever medicines that has to be given. Incrustation is it is mostly occurring in the urostomy because of the continuous alkalitic or infected urine may be resulting. So in that case we are advising the patient to take more liquid and to take the vitamin C in a diet, which will help to the that absorb the incrustation. Next is the peristomal candidiasis. This is the infection which will be caused because of the candida, and it might be because of the prolonged exposure of fecal and urinary effluent or diabetes mellitus. So for this purpose we are advising to the antifungal medications to the patients. So all these are the complications which is mainly we can manage or we can prevent if the patients early if managing by the preoperative phase by good counseling or stoma marking or evaluation of the stoma. So it can be prevented. So good post-operatively assess the stoma, and as well as if any complication, it has to be come to notice to the surgeons, which will help to prevent the further complications. Thank you.